Then we're going to cover cross-sectional studies and registries. And I have a few examples from urology as well. And I've been doing this for the last 4 years for ASU. And of course, people from other parts of the country beyond the South have also been joining. And except for the COVID period, we also had in-person final sessions, firstly at Hyderabad, which Dr. Surya Prakash hosted. And last year, Dr. Arun Chawla hosted at Manipal. So we all got together and met each other. So that's what, as a quick introduction for you, Dr. Goel. So if you, as the editor, if you could say a few opening remarks on the importance of, asking the right research question and writing the objectives, as well as cross-sectional studies and registries, after which I will get going. Dr. Goel.
Thank you so much. Thank you, Association of Southern Urologists, for organizing this meeting and inviting me as an expert for the expert opinion. I have heard Dr. Xavier before in the Chennai USICON. So I attended that session and I really enjoyed attending it. And I'm sure everyone will love your presentation and learn from it. Number one, I think the topic that you are covering is postgraduates. I hope postgraduates have joined, because these are the two things that, because they have to write a thesis and the time is very limited. They get about 2 years to plan a thesis and complete the entire thing.
His voice is breaking. Sorry for that.
Study is one of the most popular method. Actually, most of the theses are either collecting, or they are cross-sectional studies. Okay, so that is. I'll stop my video.
Yes, sir, no problem.
I think that will the signal might improve. So what I'm saying, the questions that are being covered today are extremely relevant, especially for the postgraduates, because these are the things that need to be answered during a thesis, when they are writing a thesis. So the writing a research question, thinking about it, writing a protocol, and then doing a case control study is very, very important, actually. So I hope this presentation is going to be useful for everyone. Thank you so much.
Thank you, sir. Thank you.
Over to you, Dr. Xavier.
Right. Thank you, Dr. Goel. So once again, my request to all of you is to have your videos on, please. I've said this last time as well. I don't like to see Dr. Ginnell. How nice it is to see you. Good, wonderful. He always joins us and has a nice smile. And yeah, rest of you. And keep in mind that see, I like to speak to people and I get my energy from people. If I can't see people, then no energy. Okay, all of us have had a busy day, and it's the middle of the week. So the more people I get to see and interact with, I always have all of your faces in the corner there. I'm seeing you and I get responses from your facial expression, and we continue. Okay, so in case some of you today are not able to keep your videos on, please arrange for it next time. Okay, and let me also tell you very categorically, the moment you have your video on, your attention increases that much more. Or in other words, the moment you switch off your video, your attention diminishes considerably. So for your own good and for my sake, please have your video on. Okay, so I see that few people have responded and most other people have not responded, but that's okay. We get started. Okay, so my first talk is on a very fundamental issue. Okay, or I think just as we get started, just like Dr. Goel just said, these are fundamentals, and then we need to get them right as we get started. Okay, so once again, a few reminders from last time. Please, all of you, buy an expensive notebook. Dr. Chandramohan has got an expensive notebook. He showed it to me.
Good.
So how nice. There we go. I'm sure that costs a few hundreds of rupees. Satyanarayana, let's see your expensive notebook. Fantastic. Good. Thank you very much. That is much appreciated. Please write lots of notes. Don't ask me for my slides. Okay, it's not that I'm putting my slides that nobody else in the world knows, or that is so. Oh, Dr. Kannan, so nice to see you, sir. Good evening.
Yes, sir.
According to me, he's the youngest student in our class, isn't it? Always so enthusiastic and always, energetic. Welcome, sir. Lovely to see you.
Good evening.
Okay.
I missed last meeting, but I will not miss further.
Okay, sir. Welcome. Always nice to see you, and your enthusiasm is amazing. Okay, so as I told you, please don't send me a message. Send your slides. I want a recording and all of that. Nothing I'm telling you is so unique. It's not available anywhere in the world. No. Okay. So the moment we tell you, I will send you the slides, your attention drops that much more. Okay. So please make notes and let's learn actively. If you have reached here to become a super specialist doctor, your ability to access and retain knowledge is phenomenal. So let's keep this as active learning. Okay. One more thing, we would like a volunteer to summarize in 2 minutes what we did this time or in this session for the next session. In fact, last time also I asked volunteer. Do we have a volunteer who can in 1 minute summarize what we did last time? Anyone, please? Would you like to summarize what we did last time? Any volunteers? Okay. Anybody would volunteer for the next time? So you make some notes. In 1 minute, you need to just say, what did we cover?
Yes,
okay.
sir.
So Satyanarayana, would you volunteer? I see your
Yes, sir. I have made some of notes from the last class.
Oh, why don't you go ahead? Go ahead in 1 minute, please. Maybe you can take even 2 minutes and summarize. Just list it out. Don't need to explain too much.
Okay, sir.
This is what was covered. Yeah, please go ahead. Excellent. I'm so happy.
Yes, sir. There are two things. First one, the clarity on fundamentals. The second one, get to know your colleagues. The first one, on the clarity on fundamentals. The first point is health research and study designs. Then second one is about to learn biostatistics so that we can combine the data. Then third one is the research management, how we manage money and materials and methods.
So Satyanarayana, in other words, these are the 3 parts of the course. First is research designs. Second one is data management and biostatistics. And the third one is research management. Managing man, materials, and money, 3 M's. Okay. And many times doctors neglect that part and it gets messed up. So it is like a triangle. All 3 corners, equilateral triangle. All 3 are important. Okay, research designs, biostatistics, data management, and research management. Okay, what else, Satyanarayana? Good.
Okay, sir. And you did tell about what is research and why do we do research and research questions and all we are going to discuss today. And you told us to buy some notebook and good pen and videos on and all those things.
Yes, very important. Please repeat that. Buy an expensive notebook so that you don't throw it away. Okay, so spend a few hundreds on that. Or on a weekend, if you go out and have a nice dinner, how much would you spend? At least half of that you spend on a notebook, which you hopefully will keep for life. You'll show to your grandchildren and say, see, you know what? In 2025, I did a research methods course and I still have that book. Okay, so I showed you my book that I have, right? So here is an expensive book that I bought. I bought this from Stanford University when I went there a few years ago. And yeah, this is probably, I can't see the price here because Americans don't put the price here. I think this is probably $18 or $20. A lot of money. Okay, so like that, please buy an expensive book. Keep your video on for your own good because your attention will increase that much more. And I also get to see you. See, now I'm only seeing a quarter of the people. Rest of them, I don't know where they are. Okay, whether they are there. Okay, now for next time, who is going to summarize this one? This session. So can we have a volunteer?
I will do.
Chandramohan, you want to do?
Yes,
Fantastic. Okay, great. Okay, lead from the front. Okay, great. Thank you very much, Dr. Chandramohan. Okay, with that, let's go ahead. And I have time exactly. I have, I think, 62 or 63 minutes from now. Correct? So we are going to close at 7:45, isn't it? And give me a few seconds to sort out my slides. Okay, good. All right, so let's get going. Right, so the very first topic that we need to do, technical topic, is before we do research. Last time we did what is research. Research is asking a relevant question, important for us, okay, and answering it reliably. RE research, RE relevant, RE reliable. All three are REs: research, relevant, and reliable. Okay. Now that we know what research is, how to get started, we need to know how to construct a research question. To answer that research question, we need to have objectives, and to achieve those objectives, we need the right research designs. Fundamental, very, very important. Okay, and as I told you, the objective of this whole program is not to make you terribly knowledgeable and experts, whatever, but to clarify fundamentals. Once we clarify fundamentals, then you can go ahead. It is like opening the first big door of a fort. If you've gone to Ajmer Fort, or if you've gone to fort in Agra, you will see there's a curved road, never a straight road to the entrance of the fort. You know why? Okay, but once you open that, it's very difficult to open a door that is closed. That is clarity in fundamentals. You open that door, rest of the beautiful fort is available for you. So the beautiful world of research is available for you if we clarify fundamentals. And it took me 2 years as an associate professor. In 2005, I went to Canada, McMaster University, and learned from some of the world's best teachers in clinical research. And here am I crystallizing it for you 20 years later, right? Okay, so here we go. Outline. What are we going to do? What are the components of a research question, right? Next, where to find research questions. What do we mean by aims, objectives, and hypothesis? All three we'll do. And I'll give you an overview of different study designs. And as a second part today, we will do cross-sectional studies and registries, not case control studies. I think Dr. Goel didn't hear me well enough. So he said case control. Not case control, we're doing next week. Okay, we already did this. What is research? Asking a relevant question and answering it reliably. This is what research is about. We discussed it last time. Why do we do research? To make a difference to humanity. That's all. Okay. So all the other things that we go after during research. Now you ask some of the faculty, why do you do research? Or to get a publication. Why do you get a public? All P's are there. There are several P's. I don't know if I told you this last time. Did I tell you last time, Dr. Chandramohan? I forgot a bit. As to why people do research. Most people in academia, they do research. If you ask Dr. Arun Chawla in Manipal, there is a big pressure for people to do research because we need publications, NIRF ranking, and all of that. The academics are being pushed. Okay, so most people do research to get publications. Okay, now all of you, residents, you're doing research so that you can get your thesis done. Okay, so most people do research to get a publication or a thesis. P. Okay, why do you want a publication? So that you get another P. What is that? You get a promotion. Why do you get a promotion? You go one level up so that you get little more money. The other P is paisa or property. Oh, sorry, prosperity, little more money. One more P is there. Now, once you start publishing and people start reading, okay, and you become a little more senior, you get promotion, then you become professor. In academia, you become professor. Okay, that's another P. Then people start inviting you. You become popular. You become keynote speaker. Those are the other P's that people go after. I thought of this about 3 years ago. I was writing down in one, why do people do research? And then when I do full day workshops, then I ask people, why do you do research? Then they tell the truth. Okay. But for us, I'll put a exclamation mark here to make a difference to humanity. All the other P's will follow. Can I do research to find the cause of a particular condition? Can I treat it better? Can I improve on my surgical procedures? Can I improve on my post-operative care? All that comes from research. Okay, today, whatever guidelines you have in urology and whatever your seniors are telling, all that comes from research. Okay, so now parts of a research question. Now I'm going to request you to write a research question in your book. Please write a research question. Please write a research question. I'm going to stop sharing my screen for a little while, and I'm going to request all of you to write your research question. It could be your thesis research question or something else you're thinking about. Please go ahead and write your research question. I'll give you another 30 seconds to write your research question. All right, good. If we had more time, I would have asked you to read out your research question and we could have discussed it. Today, we don't have that much time. So I will go back to my slides. Okay. Now, the first thing, like everything, there are components. A big thing has components. It's made up of parts. A simple pen, if you take, is made up of parts. A cap and a body and a refill and a thing. Anything we take is made up of parts. Just like that, a research question also has parts. And I'm going to tell you now what are those parts. And by the way, these components were written by researchers from McMaster University in Canada in the 1970s. A very fundamental issue. So more than 50 years ago, they wrote this in the 1970s. So the abbreviation is PICO for all studies. And for studies that have follow-up, we have T as well. P stands for population or patient or participant, all P's again. Who are we talking about? Who is the research on? I stands for intervention or something that I'm interested in. INT, both are INT. I'm interested in risk factors. What is causing? It's not an intervention. Okay, it's what I'm interested in. Sometimes people say, okay, don't call it intervention. Okay, in observational studies, we'll call it exposure. Okay, so instead of PI, we can say PECO, PECO, intervention. C is comparison. All worthwhile studies have a comparator. Compared to Western countries, between males and females, older and younger, with surgery, without surgery, right? People who came early for surgery versus people who came late for surgery, people who were mobilized early versus others, right? So these are all comparators. O is the outcome. What is the disease condition I'm looking at? Okay. And in follow-up studies, cohort studies have follow-up, clinical trials have follow-up. In them, we look at time. So these are the parts of a research question. So please go back to the research question that you wrote just now. Maybe in 2-3 lines, you've written that research question. Just see if PICOT is there. And next to it, write these abbreviations. Just write it. We don't have time for discussion today, but just go and write. And quite likely, many of you have missed out a few of the components. Okay, doesn't matter. So this is the first learning we have had. The components of a research question. All good, worthwhile research questions have at least these 4 components. And in follow-up studies, which is cohort and clinical trials, we have the component of time as well. These are the parts of a research question. Okay, next, what are the categories of questions? What kind of questions can we have? We can have the following kinds of questions. How much of a problem there is? How much of bladder cancer is there in Karnataka versus Andhra versus Telangana? Kerala versus Tamil Nadu? and what kind of bladder cancer do we have? Right? So how much and what type? Next question, research question we have is, what is causing this? What is causing this? And are these risk factors cause a particular condition, right? And are these risk factors different in different parts, in older versus younger people, in males versus females? All right. Next, how do I diagnose this? How do I diagnose this? What is the fastest way to diagnose prostate cancer? Fastest, least expensive, most reliable. That's what our diagnostics are about, right? That is a research question. This is diagnostics research. Okay, will a simple, blood test do? Or even easier, can I just use urine? I don't even have to puncture a skin. Can I use urine? And how reliable is it? Sensitivity, specificity, likelihood ratios, ROCs, right? How fast can I diagnose? What can I do to reduce the burden? What interventions can I do? Okay. What if you had one tablet? It costs 100 rupees. One tablet you take, prostate cancer disappears. Sorry, then all the urologists will be out of business. You won't have surgeries to do. All right. So remember, research is for the betterment of humanity. Okay. So intervention. Okay, how quickly can I diagnose and can I do the least invasive surgery so that patient can go back home the next day and it never recurs? So research on that as well, intervention. And finally, prognosis. What happens over a period of time if left untreated? That these are the different categories of questions one could ask during research. Next, where do questions come from? I don't know in reality whether an apple fell on Newton's head, we don't know. But do research questions land from the sky or from a tree? Or should I dig down very deep to find research questions? Where do they come from? Or when I'm relaxing in a bath, do research questions come to my mind? And do I jump up and run naked on the street? Who did that? Anybody? Quick.
Sir, unmute, sir. Krishnaswamy, sir.
Doctor.
Archimedes saying Eureka.
Absolutely fantastic, sir. Thank you very much. Archimedes, he figured out something which was bothering him in physics, and he figured it out while he was lying naked in the bathtub. He ran up and he was so thrilled. Eureka. Okay, so where do research questions come for all of us? Patients, an unusual patient. Hey, what did this happen? Unusual presentation. Okay, Kaposi sarcoma. What did that lead to? Kaposi sarcoma discovered a few decades ago, that led to the discovery of
Glioma.
general. Sorry, sir.
I think glioma.
HIV.
Sorry.
HIV. Right? They went backwards and then they figured out that a large proportion of men who have sex with men were developing Kaposi sarcoma. They went backwards, and then they found that's how HIV was discovered. So like that, patients. Okay. Other papers, a fantastic source of questions is conclusions from other paper or the last paragraph in a well-written discussion. The last but one paragraph, not the very last paragraph. The last but one paragraph usually says limitations of the study and what we could not figure out in this. It's a good research question for you to pursue. Okay. And they'll say next steps. This is what the next research should be, right? Other papers. So we need to read that carefully. Conferences, people say, this is how we figured it out, but still this is not known. This is a source of next research. Students, undergraduate students, they ask good research questions. Presently, I have 9 groups of undergraduate students who I'm mentoring. I spend a lot of time with them, right? Today, I was working with a group of students who wanted to look at cognitive impairment in children with type 1 diabetes. Well, challenging question. So and my approach to mentoring students is you come with a research question. I will teach you how to ask a research question. So my request to all of you faculty here, when you have your next MCH DNB resident coming in for thesis, please do consider asking them to come up with a research question rather than you giving them the research question. When you give them the research question, it is your question. So the student will always say, he gave me the question, she gave me the question, and that's why it is difficult for me. That's why I'm not finding patients. Or that's why my patients are not whatever. Okay, so please consider that. Next, most importantly, a mind that is asking questions, a mind that is restless, like Swami Vivekananda said, a mind that is constantly questioning for the betterment of humanity. Or in science, we say a mind which has a scientific temper. Temper does not mean anger all the time. Temper is a short form for temperament. Okay, so do we have a scientific temperament? Now I'm going to give you templates for asking research question. Template for cause. Do patients or people who have a particular risk factor, that is what I'm interested in, PI, okay, compared to those who don't have that risk factor. Clearly, people whose PSAs are high versus those who don't have PSA, definitely, you know the answer, okay, more likely to develop a particular outcome. Template for cause of a particular condition. Template for diagnosis among patients with a particular condition. What is the diagnostic accuracy? This is of this new test, that is my intervention, compared to the gold standard in detecting a particular disease condition or an outcome. This is template for diagnosis. Template for therapy among patients with a particular condition. Does drug A, surgical treatment A, that is our intervention, compared to standard surgical treatment or drug B or placebo, that is our control, reduce or modify complications or death. This is our outcome. If it is a clinical trial, we will say over a period of time. Typically, oncology trials are 5 years. What is 5 years survival? Isn't it? That's a question we ask. Template for prognosis among patients with a particular condition. Does a particular biomarker or a physiological parameter? This is our what I'm interested in. What I'm interested in is a prognostic marker. Compared to absence of the factor, make them more likely to develop a particular complication, a progress of disease. This is our outcome. Okay, friends, I have given you now templates. In a very short, crisp sentence, you can put all the 4 or 5 components. Okay, and here you can add T as well. Complication of progression over 6 months, 1 year, 5 years, etc., etc. Right? Yes, Dr. Kanan, please.
Yeah. Can you please show me the slides? I'll take a snap because I want to take apply this when I'm writing a review article. I want to fit in where I fit in.
Okay. Quickly,
I'll
you
take
can
a quick snapshot.
Okay, quick snapshot. You're welcome to take snapshots, but don't ask me for slides.
No, I won't ask for slides.
Okay,
Yeah.
next.
Diagnosis, yes. Therapy, yes. Prognosis, yes.
Okay, that's it.
Thank you.
Right? So what is even better is I use a Mac laptop, so it is Control Shift 3 F3. So that will give you a screenshot on your laptop itself. But if you are using a Windows system, it may be slightly different. You sometimes have a screen print as well. You can do that, so you'll get better. Okay, let's move on. What is aims, objectives, and hypothesis, and how to write it? Aims is overall what we want to achieve with our research. Let us say one of you is very passionate about bladder cancer all your life. Okay, you want to overall reduce bladder cancer. In 1994, I began my research on cardiovascular disease. I'm still doing the same, but I've gone many steps ahead. Overall, what we want to achieve, I wanted to reduce cardiovascular disease in India. So step by step, we've gone ahead. You want to reduce bladder cancer in India. First, we find out burden, we find out causes, then intervention. Now, you know what I'm working on? There are lots of things we know about cardiovascular risk factor reduction, but it's not reaching people, particularly the vulnerable. So that is where my research is. I have lots of funding from the Indian government and outside to be doing this kind of research. So that is aims. Objective is the specific steps to achieve that aim. And there are two acronyms on how to write your objectives. So at the end of this, you can take a screenshot. SMART means your objective must be specific, measurable, achievable, and relevant. That is your SMART. Are your objectives SMART? Can your objectives be finer? Finer is feasible, interesting, novel, ethical, and relevant. So as you see, relevant is in both places, but that's okay. There's a little bit, I mean, two different people came up with this. I don't know who exactly, but I acknowledge them for coming up with these acronyms. Then what is hypothesis? Hypothesis is a statistical statement that is tested by your experiment. You either prove or disprove your hypothesis. So you can take a screenshot now quickly, and let me move on. Right? Okay, objectives. We have primary objectives is the main question you want to answer. It is statistically powered. Secondary objectives are also important. They need not be statistically powered. Okay, and you want to gain more knowledge in that area, right? And it need not be statistically powered. So this is aims and objectives, right? Oh, sorry, one more thing. Secondary objectives are exploratory. They generate hypothesis for your next research question, and that will be your primary objective in your next project. So your secondary objectives are valuable. What is hypothesis there for? Hypothesis is a research question that is rewritten, analyzed statistically for significance. I'm sure all of you have heard about disproving the null hypothesis, right? In fact, many research courses start there, and that's where doctors lose it. That I have. Okay, so I usually don't go there. We leave that part. So that is hypothesis. Now, from research question to hypothesis, how do we move? Research question guides the study design. At the end of this, please take a screenshot of this, because this is a nice crisp summary of research question right up to hypothesis. Research question guides the study design. I'm shortly going to tell you about study designs. Objectives guides the study methods. What methodology am I going to follow? And the hypothesis guides what? This is the last line. Get ready, Dr. Kannan. Hypothesis guides the statistical analysis. What is my hypothesis? Is it a superiority hypothesis? Is it an inferiority, equivalence hypothesis when it comes to clinical trials? Okay, so this is a nice crisp summary, and please, all of you, keep that in mind. You can take screenshots or write it down in your book, which is even better. Okay, now research study designs. There are quantitative designs where we have numbers, we measure, and we make statistical inferences. Invariably, all your research projects are quantitative research projects. There is also qualitative research projects where we don't collect numbers. We ask people, what do you feel? What do you think about this? What are you worried about? Okay, right? And so no numbers for a deeper understanding of what people are going through. This is in medical research. I'm not talking psychology research. Okay, we're going to have, a transplant for you. What are you afraid of? Okay, say, I'm not so afraid of the transplant surgery. I know I will recover within a week or two, but I'm afraid one of my cousins, let us say, had medications for a long time. Doctor said it will reduce your immunity. Poor man, he got fungal infection. He had to be admitted in the ICU, and he was on respirator for so long. And after the transplant was okay, but he died due to respiratory infection, right? So I'm worried about that. I'm not worried about the surgery because I trust you. You'll do a great job. I'm worried about my immune system after that, correct? So okay, so that is qualitative research. Okay, now I'm going to show you a very complex chart. Don't take a screenshot of that because it'll mess up your life. Okay, so I'm going to show you this, which covers all of the possible research designs. Okay, I'm going to go through this very quickly, purposely. Primary research and secondary research. In primary research, we have basic, this is primary research, okay, and secondary research. We have basic research, clinical research, and epidemiological research. In basic, you have so many different types, okay, including genetic, this, that, whatever. Clinical research, we have experimental and observational. Experimental, we have phases of clinical trials. Observational, we have prognostic, diagnostic, secondary, single case report, all kinds of observational studies. Epidemiological, we have experimental, intervention, field, group. Here we have cohort, case control, description, so many. And this side is meta-analysis or systematic reviews and meta-analysis. Lots of different study designs. Don't take a screenshot of this. Your phone will explode if you take it. Okay. Therefore, let us simplify this whole thing. My job, what did I tell you? I'll simplify and I'll give you clarity in all this. I could have taken 45 minutes to explain this whole thing to you. Okay, but let's simplify it. Right? Life makes sense when it is simple, clear, and crisp. So let us look at this very simple flow chart, which came in the 1990s in the Lancet. Is more than 30 years old. Old is gold sometimes. Okay. The first question we ask is, did the investigator assign an exposure? It's a research terminology to simply say, did the investigator do something different to the patient? Did the investigator do something different to the patient rather than routine clinical practice? If yes, it is called an experimental study. I'm experimenting something. In the experimental study, was there random allocation to 2 or more groups? If yes, it is a randomized controlled trial, RCT. If no random allocation, but still did an experiment, it is called a non-randomized controlled trial. The other names for it, if you want, you can write down. It's not on the slide here. It is called quasi-experimental studies, QUASI, quasi-experimental studies, or before-after studies, or sometimes internal comparator studies, all kinds of names they give, but they're all non-randomized. Clearly, a randomized control trial is far superior to any non-randomized design. Okay, let's go to the other side. The investigator did not do anything special, okay, just observed people who are there. Did not change treatment, okay, did not give a new drug or change the preoperative strategies or intraoperative procedures or postoperative care. Nothing was changed. In the observational study, is there a comparison group? Yes and no. If there is no comparison group, please keep this in mind. It's called a descriptive study. I'm going to show it to you. It's called a descriptive study. And a case report is a descriptive study. A case series is a descriptive study. Okay. Case report, I'll write CR, single case report, right? Or a case series. Now, I'm going to tell you something very important. Please write it in your expensive book. Okay. Now, when you do a case series, one after the other, you are getting these patients, you do a case series. Maybe there are 24 or 44 or 82. Okay. Big number case series. Okay. Over 2 years, you collected something unique. And what are you tempted when you have 82? Hey, what is the difference between males and females? What is the difference between those who came early versus late? What is the difference between those who took this medicine and, hey, you know what? Call the statistician. Do some chi-square test. Do some t-test. Fisher's exact test. Oh, no. Okay, not normally distributed. Kruskal-Wallis or Friedman's test. Do this, do that. Please do not do any analysis in your case series. Just describe them. Okay. Okay, you can say percentages. Okay, so many were males, so many were females. Okay, don't take mean age here, and do a t-test there and say, okay, because they are not analytical studies. Now I'm going to tell you, and today we're going to do cross-sectional studies in detail. So if you have a comparison group, yes, it is called an analytical study. Okay, the direction here, the direction an analytical study takes, based on that, there are 3 designs. First, follow me one at a time. Sorry, 3 designs. One, follow me one at a time. Cross-sectional study. Exposure and outcome is at the same time, at one time. Invariably, 80, 90, 95 sometimes % of postgraduate thesis are cross-sectional studies. very easy design to conduct, and the very easy design to make a mistake because we think it is very easy. People make mistakes with cross-sectional study, and today I'm going to tell you where are our common mistakes and how to avoid them. Okay, friends, very simple. You go to there is a sampling strategy which I'll talk about later. You go to a patient, you collect whatever data you want at one time point. Thank you very much, and that's it. Okay, let's move now to the second one, case control design. You identify your case and you collect risk factors from the past. Let us say, once again, let us say bladder cancer. Okay. And let us say this is in the 1970s and 80s when we did not know very much that tobacco caused all of these cancers. All right. And then you will ask for exposure of tobacco from childhood onwards. That is for the case. Then what you will do, remember, outcome has already occurred because the patient has bladder cancer now and you're going backwards. Then what you do is you find a matching control, one other person who is of the same sex, okay, and that's why I did not say prostate, okay, who's of the same sex and does not have bladder cancer. You're reasonably sure the patient does not have bladder cancer, and I don't think you need to do a cystoscopy in a control to prove that the patient does not have bladder cancer. Whatever is reasonable, you will do, and then you'll go backwards and you will collect exposure the same way. Okay, last design, cohort study. Cohort, the meaning of the word cohort means, or cohort means a group of people with something in common. You identify them and then you follow them up forward. And one of the two key characteristics of a cohort: group of people with something in common and they do not have the disease. Don't worry, we have a whole lecture on that. That time you can write more notes. Okay, you start collecting exposure, you follow them up till you get an outcome. It's a very powerful and highly valuable observational study design, but very difficult to do. Very difficult to do because primarily to follow up, and there are so many biases and confounders that we have to deal with. We'll discuss all of that. Okay, friends. So at the end of it, you need to remember only 5 study designs: randomized control trial, non-randomized control trial, cross-sectional studies, case control studies, and cohort studies. For all relevant clinical designs can be done here. 98 to 99% can be done here. Some diagnostic studies have slightly different so all clinical research can be summarized in this. All right. This is a summary of the direction. Okay. Temporal direction is over time. How is the study progressing? Cohort study, you collect exposure and you go forward to collect outcomes. Case control, outcome has already occurred in the case and you're going backwards to collect exposure. And in a cross-section study, it's at one time point. All right. So where do we use these different study designs? You want prevalence. How much of a disease is there? A cross-section study is more than enough at one point in time. How many new cases? Incidence means new cases. Over a period of time, you have to do only a cohort study. Group of people without the disease, follow them up for 1 year. Over 1 year, 1,000 people, 100 people develop this, incidence is 10%. Okay, there are various ways in which you give incidence. Next, what causes a particular condition? You can do a cross-sectional study, you can do a case control study, you can do a cohort study. All 3 give you the answer. In terms of reliability, cohort is the best and cross-sectional is the least reliable. It's not a bad design, it's least reliable. Okay. Next, prognosis. What happens over a period of time? No brainer, cohort. Natural history, again, no brainer, cohort. What are the research questions left over? One more is left hidden. And that's sometimes the most important question we can ask. What is left over? How do I treat a condition? Isn't it? What is the treatment effect of a particular intervention? Only a randomized controlled trial will tell you. No other design will tell you. Sometimes These pharma company people will come to you. They'll give you free samples for 50 patients, 100 patients. Sir, madam, please give this free samples and little bit data you collect. For everything you collect, we will give you so much money, or we will take you to this exotic place for a final meeting. Okay. So they give you the samples and then they collect this data. Then they go, they do some jadoo, and then they'll say this brand is better than that brand, or this drug is better than that drug. Totally unreliable. Please don't waste your time on that. Okay. After this course, at least your name should not be associated with studies like that. If they want to support your research, let them give funding. And I worked with many people came and asked me, oh, sir, you do this, you do that. Can you do this? Can you do that? I said, no. Okay. If you want to support research, here is the way in which you can support, give money to our institution, and then we'll design. We'll, of course, keep you informed. Okay. So please keep this in mind. Treatment effect, only randomized controlled trial. And sometimes they'll tell you this is a phase 4 design we are doing. Can you do that? Phase 4 design has its purpose. Post-marketing surveillance has its purpose, but they should not speak about efficacy in a non-randomized setting. All right. Clinical guidelines, where do they come from? These are statements written by Urology Society of India, ASU, right? Responsible body societies or the government. And they use evidence from well-conducted research studies. And the best evidence comes from systematic reviews and meta-analysis of high-quality RCTs. High-quality RCTs is important. Let me summarize. Research question now has 5 to 6 components. Research study designs are now, in your mind, clear and well-defined. Simple, clear, well-defined. A research question can be answered by different designs. Some are better than the others for specific research questions. Okay, Dr. Kannan, yeah, go ahead, please. We wanted to take a picture. All right, good. So that
if possible, I would like to be the person who would summarize. That's why I'm making a note.
Yeah, Dr. Chandramohan beat you today. Next time you should be faster than him.
No problem, sir.
Okay.
He is our boss. Kannan sir, he is a student forever, boss for all.
Wonderful, wonderful. Okay. So now we're going to go on to cross-sectional studies. But before that, any comments or questions from y'all? My only thing is, even if you don't remember everything, but of what I told, are things clear in your mind? Clear in your mind. That's the important thing, right? You may not have, listened and remember everything, but is there clarity? Good. Okay. Dr. Rahul says yes. Yeah. Any comments? Please feel free to make some comments. I can also take a little 1 minute break from talking. I'll sip my tea.
Yeah, so I'd like to, emphasize what you have already mentioned. So you mentioned about the primary objective and the secondary objective. So I think this, and you mentioned although, but I think this needs to be emphasized again, that the sample size has to be collected based on the primary objective. So often what happens, we just enumerate when a student is writing a thesis, especially, they are not aware, what is the primary objective, and they just enumerate, 1, 2, 3, 4, not realizing that what is the significance of these terms actually. So I think the sample size has to be calculated based on the primary objective. And naturally, the power of the study is calculated based on that. And I think you very, very nicely summarized the entire thing. So, in a very simple fashion. So, all the complex things in a very simple fashion, as always. So, I think the part 1 has been really beneficial for everyone.
Breaking, sir.
Sir, can I ask a question? Just a simple question. Who calculates the sample size?
Rahul Gupta is from the Jammu. We have announced this program for the entire Urology Society subsectional. He is a very senior laparoscopic endourologist, trained from Nadiad and close friend of us. Dr. Rahul, sir, please.
Sir, this is very important to calculate the sample size. Who can help us to calculate the sample size so as to get an adequate power for the study?
Right. So we have a whole session, Dr. Gupta, on sample size calculation. I'm going to give you, that is the first lecture in part 3. Okay, I hope you have the, do you have the entire program? It's on one sheet. If not, Dr. Chandramohan can send it to you. What are the principles for sample size calculation? How to calculate sample size for simple studies? And I'll give you a demonstration of that as well. But the take-home message from there is always work with a good statistician. Now the next question which you will ask, I don't have answer to. Where do you find good statistician? I'll tell, come to St. John's. We have whole department of statisticians. No, but I will tell you how to go about it. Okay. But Dr. Goel is right about the importance of the primary question and the primary objective. Yes, Dr. Krishnaswamy, please.
Yeah. I remember one of your famous statements during the last class I attended, that the descriptive study should be thrown out of the window, if I remember correct, because that is a study which we should not rely upon getting some information. Is it still holding good, or am I remembering it correctly?
I hope I did not say throw it out of the window, or if I said it in that many words and maybe I was misunderstood. It is a good start, but don't make conclusions based on that. Don't make comparisons and conclusions. A case series should help us to do a high quality cross-sectional study, and that's what we're going to do now. All right. Okay, let's dive into cross-sectional studies. And we have a lot to cover. Now I want all of you to put on your thinking hats. Now open up your books, and I'm going to give you a series of questions to think about. So just put the number and scribble something. Okay, answer, because you get only 15 seconds to answer. Okay, bunch of questions just to stimulate our thought. I'm not going to ask you for answers. You don't have to show it to your boss or your wife or your husband or boyfriend, girlfriend. Nobody you need to show. Okay, so some questions to think about. Firstly, 3 purposes of cross-sectional study. You put 1, A, B, C, you write. 15 seconds, quick, just scribble quickly. In other words, why do we do cross-sectional studies? Next, what are 4 key issues in cross-sectional studies? Next, sampling is one of the 4 key issues. All right. But my question is, what is the main purpose of sampling? Why do we need to do sampling correctly? What is sampling and why to do it properly? Next question, what is bias according to you? You hear this all the time, no? Simple English word actually. But in research, what is bias? Next, how many biases are there? Put one number. Put one number. How many biases are there? Number 5. 5 equals, put one number. Name 2 biases in cross-sectional studies. 6A, 6B. Okay. Next question. What is the meaning of sampling strategy? Sampling is something. What is sampling strategy? Next. Now, what are the 2 main methods of sampling? A and B, methods of sampling. Under that, we have many main methods of sampling. 8A, 8B. 9. Of the 2 methods, which is more preferred? So you can answer this question if you got the 8th question right. Don't worry if you don't know the answers. You're going to get all these answers just now. While analyzing a cross-sectional study, when we analyze a cross-sectional study, what is the key statistical parameter? When we analyze, right? Descriptive analysis is mean, median, mode, percentage, whatever. But to make some conclusions, what is my key statistical parameter? Okay. Next, you know what? Don't write answers to this. Okay, we're going to run through this. What is a patient registry? What research designs are used in a registry? What are the 3 purposes of a patient registry? Who are the key stakeholders in a patient registry for whom registries are important? Do you know any registries in urology in India? Any? Okay. So this is what we're going to discuss. Okay. So 14 different questions I asked you to stimulate your mind. Okay. We're going to get answers for all of this now. What are we going to do? We're going to do cross-sectional studies and registries. Why do we do cross-sectional? What are the design? What is sampling? What are biases? How do we analyze? And I'll give you a few examples, including from urology. What is a registry? Why do we do it? Okay, how do we analyze registries, and some examples in registries, including some registries in urology we will look at. Okay, cross-sectional study is an observational design. We study exposure and disease status at one point in time. We're not going to follow up. We're not going to go backwards. In a cross-section of the population at one point. If it is a simple study, in 10-15 minutes for one patient, it's over. All right. We may make some measurements. See, sometimes people get confused. Oh, I'm taking, what do you say, bladder and endothelium is called, right? Or scrapings from the bladder. And they say, no, it is not cross-sectional study, it's intervention. I'm doing intervention. I'm doing cystoscopy. And no, you're taking this to diagnose. You're taking a blood sample to diagnose. You may take a kidney biopsy to diagnose. Right? Okay, it's still, so people sometimes say, no, it's an interventional study. No. Okay, so in a cross-section of the population. So the study exists only at this point in time. Another thing people get confused, but my study is going to take 2 years. No, for a patient, it is at one point in time. Your sample size is 1,800. Okay, and that took you 2 years to collect. That is not a 2-year follow-up study. Okay, for one patient at one point in time. So remember, friends, I told you on day one, I'll give you clarity in what we have been doing. And you know all these things, many of these things. So, sometimes I give this analogy. It's like you have a window, but the glass is dirty. I'm helping you to clean that glass so that you can, on both sides, we'll clean it on both sides so that you can see clearly outside. Okay, why do we do? Purpose: assess burden, characteristics, and status of the disease in the population. You may want to provide health services. You may want to change certain risk factor exposures there. Asbestosis, hey, you stop that factory, or people move away from there. Okay. You want to identify risk factors to generate hypothesis. Cause, cross-section study, you get started. Okay. Cross-section, case control, little more strength of evidence, strength of association. I'm going to tell you about association and causation soon. Okay. Cohort is the best, but cross-sectional, you get started. You can compare them in different populations, urban versus rural, South India versus North India, people living on the hills versus people living in by the ocean. Doesn't make a difference. Okay. Trends over time. Okay, so in India, since 1960s, we have data on hypertension. I did a systematic review. I'll show that to you later on. We found out over a period of time. And we say, now we are saying in the highest increase in hypertension in India is in rural areas now. Okay, it was very low before compared to urban, it's rapidly rising. Repeat measure studies to get an estimate of the association of risk factors to a particular disease. So cross-sectional study, this is our study population. Okay, there are some people who have the disease, some people who don't have the disease. So who's your study population? Middle-aged men or elderly men, let us say. Okay, some of them have prostate cancer, some of them don't have prostate cancer. And so let us say those without prostate cancer, in some of them, the factor that you're interested in is present, in some it is absent. In those with the disease, factor present, factor absent. Can you see 4 groups here now? You would have seen this, you may have seen this in a 2x2 table. I will show that to you when we do cross-section, when we do a case control design. Okay, so these are 4 groups and we can analyze them. We'll do analysis a little later. What are the few issues in a cross-sectional study? How do I find the sample? Who do I take? How do I find the sample? This is sampling. And this is where we commonly make a mistake. Now, students will say, I randomly selected patients from the outpatient department. Okay. Random selection is different from randomly doing whatever. Okay, Monday they went at 10:30 to 12 o'clock. They were there in the OPD. And then on Tuesdays, they were OT. They did not go. Wednesday, they went in the afternoon. And on Thursday, he was on leave. Friday, he went at 2 o'clock in the afternoon for half an hour. Okay. Did haphazard does not mean random. Random is a very systematic way about going about things. It's not haphazard. So what I described to you is haphazard sampling. So I'll tell you more about sampling. There are biases. I asked you this question. What is a bias? How many biases are there? Maybe when I come to that, I'll ask you on what number you wrote. How do I analyze a cross-sectional study? And finally, what are the few strengths and weaknesses? Okay, let's go to sampling. Sampling is choosing a representative sample so that my findings are valid. So when you go on Monday morning, you miss Monday morning for 1 hour. Tuesday, you miss. Wednesday, you go in the afternoon. And Thursday, you went for half an hour. Friday, you went for between 12 and 1. That is haphazard sampling. And then you say, in our OPD, this is how the presentation of this condition is. Is that haphazard sampling representative of your population in the OPD? Clear answer is no. So there is a method in which we sample. So most postgraduate theses are done in a haphazard manner and we say random sampling. Okay, right. Biases, non-responder bias. Some people will not respond to you. They'll say, no, I'm not giving you consent. I don't want you to take. Okay, it'll give you biased measures of the outcome because characteristics of non-responders are different from responders. Now you go to, let's say, a corporate hospital, many people will decline consent, right? Or if you go to a hospital like ours, where we get well-to-do people as well as poor people, as well as very poor people in our hospital, who usually responds, who will consent? People who get free treatment or less cost treatment, isn't it? So it's not representative of the entire population. Please keep those things in mind. Once again, let's look at an overview of the study design and how to analyze this. This is our target population. What's our target population? Let's say elderly men. And we want to study prostate cancer. We use a sampling strategy and we get the study sample. I'm going to tell you about sampling strategy shortly. We get the study sample. Then we gather data on both exposure and outcome. Now, we have a group of people who had a particular exposure and outcome is present. Some people had the exposure and there is no outcome, right? These are people who are exposed. Then there are people who were not exposed but had the outcome. There are other people who are not exposed and had no outcome. Now, like in physics or in machines, in inanimate machines, right? We can clearly predict what is going to happen. In biology, we can't predict. Like if everybody who were exposed, a classic example is Winston Churchill. He smoked till the age of 90 plus, and to the best of my knowledge, did not have any tobacco-related complication. If everybody smoked, got lung cancer, we don't need epidemiology, we don't need probability. Okay, so anyway, this is the overview of study design for the cross-sectional study. Sampling strategy is the next one. It's an essential, or I would even say critical component. That means without a proper sampling strategy, you're going to get spurious conclusions or incorrect or wrong conclusions. It's an essential component of a cross-sectional design. And what is sampling? Definition of sampling is here. It is a process of selecting some people or a subset from the whole population. I'll go back now here. This is important. How do I get this blue group of people from this whole sample? That is my sampling strategy. And a good sampling strategy will be representative of the population. Okay. right? And why do I need? I'm going to estimate to estimate the characteristics of the population. It is critical because the population is heterogeneous, or there is considerable heterogeneity. Okay, that's the correct way to spell it and pronounce it. Sometimes many people say heterogeneity for some reason. There is no C there. Okay, so it is considerable heterogeneity, and that's the correct spelling. Okay, because there is heterogeneity in the target population, that heterogeneity must be represented in the sample that I pick up. All right, that's the importance of a correct sampling strategy. Okay, now let's go to sampling methods. One is called probability sampling. It is chosen using a method based on the theory of probability. In fact, the introductory lecture in epidemiology, they discuss algebra and theory of probability. That is where doctors lose it. I said, oh, I don't want all this. So I'm not going to tell you people this theory of probability. We left it in high school. All right, doesn't matter, but I'll tell you what it means without going into the theory. What is the other sampling method? Non-probability sampling based on subjective judgment. Okay. And when you do non-probability sampling, please mention that. Dr. Goel, as an editor, would like to know what you actually did, and you own up to it. You mention it. You are aware and you mention it. So we use non-probability sampling methods to get our sample. He'll be very pleased and he'll fast track your publication. All right. So always probability sampling methods are preferred over non-probability sampling. So always choose this and work with a person who knows this and to do. Okay, let's go through this quickly. So I'm not going to explain this a lot. I'll run through this. Take a screenshot of this at the end of this. I'll do that quickly, and please read up more. I'm not going to promise that in the next 1 minute, I'm going to explain and make this crystal clear to you. Okay, probability sampling method, simple random sampling. Every member has the same probability of being randomly sampled. Okay, now this is important. Please make a note of it. In small sample sizes, simple random sampling is not good enough, and you need to go for, okay, systematic sampling. Okay, before that, okay, let me go to stratified sampling because I started the small sample. If your sample size is less than 100 or a few hundreds, better to go for stratified sampling. So that what you do, you divide the population into strata. And I highly recommend that don't have more than 3 strata: age, sex, and disease severity. Just these 3 strata. Okay, don't go into, the more strata you have, the more complicated your analysis becomes. Okay, and statisticians don't like too many strata. Ideally, large sample size, simple random sampling is the best. But your sample size is small. Therefore, go for random sampling. Systematic sampling is similar to random sampling, where you list out 5,000 people and every 10th person you randomly take. How do you list out? Based on some system you list out. Okay. And then you randomly, or whatever comes to your mind. Every 9th patient I'll take. Every 7th patient I will take. So patient number 7, patient number 14, patient number 21, patient number 28, and so on. Okay, so that is systematic sampling. This is stratified sampling. Next, you have clustered sampling. You divide your population into groups or clusters. Then you take a random sample of the entire clusters. Here, cluster is the sampling unit, not the individual. Okay, non-probability sampling. This is what we usually do. Convenience sampling, or less elegantly put, haphazard sampling. That's what we mostly end up doing. Most students do this. My undergraduate students, we tell them, even my postgraduate students, I explain all this, but they end up doing haphazard sampling. So we tell, write it in the journal, write it in a method section. We did convenient sampling. Whenever possible, we went. Okay, based on availability of the doctors and the patients and willingness, etc., etc. Quota sampling. Okay, I want so many males, I want so many females, I want this, I want that type, I want this type, and we do. It's not stratified sampling. Stratified is, okay, one thing, let me clarify. In each strata, you're going to randomly sample. That is stratified sampling. Quota sampling is, I need so many of this, at least so many of this, at least so many of this. That's quota sampling. Purpose of sampling, you take this, you take this, you take this. That's fine. Snowball sampling. You ask a particular participant to recruit or refer another participant similar to himself or herself. That's called snowball sampling. Okay, we don't do that much in clinical medicine. It's more in epidemiological and field studies. Okay, what is bias? Here is a definition, textbook definition of bias. It's a disproportionate weight given in favor or against an idea or a thing. This is the English meaning. Hey, this person is very biased. Okay, right? Usually it's close-minded, prejudicial, unfair, and wrong. Biases are wrong, not good to have it. Okay, I'm sure all of us did this. I as a junior doctor, when I was working in a particular institution, I used to judge people based on how they were dressed. Okay, and that's what we all do. And sometimes, you know, throughout our life, I have lots of stories to tell you. Today, no time. Biases can be innate or learned. In science, very important, please write this out. In science, bias is a systematic error. What is the other type of error? Random error. In nature, there are random errors. Nature is not biased. Nature has random errors, Mendelian randomization, whatever you'll know, right? No two trees are the same. Okay, they're not errors, they are patterns. Okay, so we allow for random errors, we account for it statistically, but in science, bias is a systematic error, and we need to avoid bias. We need to avoid bias. Okay, bias in health research. This is the textbook definition. It can occur, it's an error that occurs in the conception and design, in the collection, analysis, or interpretation, in the reporting, publication, or review of data. Look at that. Biases can occur in so many places. Okay, while you're thinking of a research question, you can have a bias. Okay, right when you submit it to Dr. Goel, and he can have bias. Okay, as an editor, you can be biased. Oh, if it comes from these kind of institutions, you know, it is not good. Oh, this person, he had, you know, his previous paper was not good, so this paper is also not going to be good. I will reject bias. Okay, even editors can have biases. Okay, it's an error. It can lead to conclusions that are systematically different from the truth. Random errors are okay, they are accounted for. In my first session on statistics, I will tell you what are the random errors, and we allow for a 5% random error, isn't it? P equals 0.05. Yeah, that's where it comes from. So this is from the dictionary of epidemiology. I've not added any line there, any word there. I have verbatim put it there, and I've formatted it so that you can read it properly. Okay, so this is from the Oxford University Press textbook of epidemiology. All right, how many biases are there? Okay, let's do a quick exercise. I know we've come to the end of our time that Dr. Chandramohan allotted for us, but how many biases are there you wrote, isn't it? So go to your chat box and just write that number and hit enter. Quickly go to the chat box, hit put a number and hit enter, please. Okay, yeah, quick, keep on hitting, keep on hitting. You have to put one number, don't put greater than. If you put greater than 0, you're correct. Okay. Those strategies are not allowed. So there are some people who are disqualified from this. I will tell you who. Okay, so we have 5, we have 9, we have 8. Quick, come on, hurry up, folks. We are getting late. So there are only 3 people who are okay. Come on, 6. Okay, so Satyanarayana said 50. That is the biggest number we have. Okay, so previous participants or people who have listened to my course previously, they are not eligible. Okay, so the numbers we had a 6, 8, and up to 10 we had. Okay, so previous participants are not eligible. Dr. Ginil was closest, but he's not eligible for this. Okay, number of biases. In 1979, Dave Sackett listed 35 biases. Within a few years, his colleagues added almost 21, grew to 56. In 1979, I'll show you that paper. Now, there is a catalog of biases which has approximately or around about 250 types of biases. So bias is a big deal. Bias is a big deal. Here is the paper that I told you. Journal of Chronic Disease, 1979. bias in analytical research. I'll tell you who Dave Sackett is another time. Please go to Oxford University website, go to Catalog of Biases, Center for Evidence-Based Medicine, okay? And then you'll have this catalogofbias.org, and you can search the catalog. All right, and you can enjoy yourself studying about so many different types of biases. Let's move on now. What are we interested in? Biases in cross-sectional studies. Number one is recall bias, and number two is non-responder bias. People with disease recall certain things better than people without disease. I'm not talking about dementia. Let's say a particular cancer or something else. They'll remember the risk factors better than those who don't have the disease. And by nature, people who respond or participate in research, right, are systematically different. They are healthier than people who don't respond. So this is nature. This is what is happening out there. Can we avoid biases? No, we need to understand it, and we need to minimize bias. The way we take consent, the way we ask questions. So we need to modify our research design. Okay, I'm going to stop here now because we have run out of time. I've not run out of energy, but we have run out of time. Okay, and what we have left out, I will tell you shortly. Okay, we have left out or what is yet to be done is how to analyze cross-sectional studies. And there are a couple of examples. And Dr. Chandramohan, if you give me 5 to 7 minutes, I can complete this. And next time we'll do patient registry.
Okay, sir. Please finish, sir.
Can we complete this one? Okay.
Yes, sir.
So we were talking about biases in cross-sectional studies, right? Okay, so let me share my slides again, and we will complete it now. It'll take me another 5 to 7 minutes maximum. And next time I'll be a little more, or maybe since we were starting up today and we had all those questions, we had, or we took a little more time. Okay, so what did we do so far? We spoke up to biases in cross-sectional studies, two types, recall bias and non-responder bias. Now, how do I analyze cross-sectional studies? We do first descriptive analysis, mean, median, mode, percentages, whatever. Okay, in this group versus that group. Then we do that is called descriptive statistics. Next, we have analytical statistics or inferential statistics. In my first lecture on statistics, that is part 2, I have a nice diagram and I'll show that to you. But for now, inferential statistics. So now we need to keep in mind in cross-sectional studies, all factors are measured at one point. Exposure, outcome, and even confounders. Next time I'll tell you what confounders is. For the first time I'm using this word, but I will tell you confounders next time. And we compute the odds ratio, very important point. And I'll tell you how to interpret the odds ratio next time. Okay, odds ratio assesses the strength of association between risk factor and outcome. Strength of association. So in cross-sectional studies, dear friends, we are looking at association. The other thing we are looking at is causation. We will discuss that also next time. But keep all this in mind. Make sure your brain is stimulated for that. What are the uses of cross-sectional studies? For conditions that are relatively frequent, long duration of expression, not suitable for rare diseases, highly fatal disease, right? And people have died even before you reach them to take data. Is not good. Okay, diseases with short duration of expression, they are not suitable. Let's take some examples and we'll conclude with that. Spectrum is a study that we did. Situational analysis of the practice patterns in cardiovascular disease management in all regions of India using mixed methods research. Mixed methods means we used cross-sectional study and qualitative study. Now, which is the most difficult part in this whole thing? Is it cardiovascular disease management or mixed methods research or situational analysis? No, in all regions of India. So I'm using this example of a study that we did to tell you how do you sample the whole country? How do you sample the whole country? And at that time, there was no data. I'm going to show you two studies done in India. These days, we have good quality data in India. When I started my research in year 2000, 2001, very little data in cardiovascular disease itself. Now, you people should think now, in urology, do we have nationwide studies? So let this be an inspiration. for all of you in ASU and USI to conduct nationwide studies in different areas in urology. Okay, research question among patients with cardiovascular disease and also physicians. We wanted to look at different things. Okay, I'll not go into the details. What are the methodology we did to answer these research questions, right? We did stratified random selection. Secondary and tertiary care hospitals, that is where cardiovascular disease goes in all states of India. That was a tricky part. It took us 6 months to finalize our sampling methods. Every week we spent hours to sort out our sampling methods. And we select centers, and within centers, we have to randomly select the physician. Otherwise, suppose we send a survey question to Dr. Arun Chawla. What will you do? Hey, come, you residents, fill this and send it back. No, we want data from Dr. Arun Chawla also. We want data from Dr. Chandramohan. We want data from Dr. Ginil as well. So we stratified and selected the physicians, and we stratified by seniority. So we gave the names of these people and told them, please collect data from them. And how do you take a countrywide sample? We had eventually 124 sites, 1,350 physicians. Let me reiterate, it took us 6 months to sort out this. So we had to list out all the secondary and tertiary care hospitals. Then we had to find a person there. We listed out all the physicians, and then by seniority, and then we stratified and sampled them. Okay, so, and a sample size, overall sample size was based on the prevalence of cardiovascular disease. So this is where, so at that time, we could not reach Jammu Kashmir, right? We couldn't find people at the time. It was challenging to reach there. And unfortunately, in the last couple of days, things have got messed up there. Last year, I'm sure many of you have also gone to Kashmir in the last few months and years. We went last year. It was so beautiful. Anyway, very sad. I hope things get sorted out, but our country is responding pretty strongly, as I can see. Anyway, 124 hospitals, 75 cities in 22 states is what we did. Once again, it took us 6 months to figure this out. Getting the data after that was relatively easy and analyzing it. Okay, here is a diabetes study in 15 states of India, done by a good friend of mine, Dr. Vishwanathan Mohan. People in Chennai would know him. He's a very popular diabetologist. He's on TV and newspaper all the time. Anyway, this is his group, which did the ICMR Indian diabetes study. Okay, so what did they do? Stratified multi-stage design, 57,000 people. First stage, they did 14 of India's 28 stages. Okay, and these, okay, we will do all of this later. So what did they do? Finally, they got odds ratios were derived using multiple logistic regression analysis. I'll tell you more about that in our next session. So prevalence in Andhra, Bihar, Gujarat. So this is how they got a countrywide sample. And what did they find? Here is a summary slide. This is by GDP. The lowest GDP was in Bihar, highest GDP was Chandigarh. What are they saying? Diabetes prevalence increases by GDP. Simple graph. But to do that, they had to go through so much of work. Okay, so this is urban, rural, men, women, etc. And these were the odds ratios that they got. What does 1.04 mean? It means that in rural areas, with every increased age of 1 year, there is 4% increased prevalence of, or 4% chance of increased prevalence of diabetes. What does male sex mean? 1.33 in rural areas, or let's go this side. In urban areas, males have a 44% increased chance of being diabetic compared to females, and this was statistically significant. I'll teach you 95% confidence interval next time. Okay, so this is overall prevalence, etc., etc. That's what they did. Okay, let me tell you a simple study that my students did. They looked at cardiovascular risk factors in coffee estate workers in India, called the CARE study. Very simple study, but it's the first report of cardiovascular risk factors in coffee estates. Tea estates, there were plenty from Assam, Darjeeling, etc. Okay, so they looked at different risk factors and what is the total, what is it in males, what is it in females, permanent workers, migratory workers, and you have all of this data and some analysis that we did and presented and published it in the Journal of Community Medicine. It's a good paper. Okay, Right, we'll conclude with, before you get angry with me, where is urology? We'll conclude with this one. Okay, so your EAU journal, okay, quality of life after bladder cancer, a cross-sectional survey using patient-reported outcomes. Okay, objective, they undertook a cross-sectional study covering 10% of the English population. That's quite a large number. Okay, they did a postal survey. And what did they find? Okay, between 2007 and 2016, almost 10 years in different regions of the NHS service, Yorkshire, North Derbyshire, etc., etc. This is what they did. And here are different quality of life responses that they got, item summary and the response scale. I'll not go into the details, and descriptive statistics. Firstly, they did age was grouped into different areas, and then the mean rating or the different quality of life surveys that they did, and overall 3,200 people were eligible, right, of which 19 died, and so completion rate was 55%. So out of 3,300 they got 1,700, 55%. So 17 out of 3,260 because 19 died. Okay, and this is what they got, and they are looking at mobility, self-care, usual activity, pain, comfort, anxiety, depression, more than one dimension. I forgot what SAH rating is, but I'm sure you people know it. So these were the different types of surgeries that were done. Okay, radical cystectomy with additional procedures. This is TURP kind of surgeries that they did, and then again with all, this is what they found, right? And these were their conclusions, and today we're not going to go into the details. All right, so with the 55% response rate by postal survey is quite good. There are many high quality studies done in India as well, and I will be sharing some of that next time. Okay, I'm going to stop sharing here, and with 1 minute to go for 8 o'clock, I will stop. And Dr. Goel and Dr. Chandramohan, if you want to come in to make some concluding remarks, we are good to do.
Thank you, sir. Thank you very much. It is a little, I felt little faster. I could catch up to 90%. I have to read. I was writing. For me, I could understand what cross-sectional study is, but bias and all, the concentration was less at the end. But we have to see again. These last 3 papers also, we have to see how they have done. You are fast, no doubt about it. But 80% you made it very crisp in the slides for the given time. Actually, you can entire year you can discuss and do this, but we understand your valuable time and our valuable time. So now Dr. Apul Goyal and Dr. Arun Chawla sir, please comment so that we will conclude the session.
I think we'll take
okay.
Apul's comment and then conclude. Apul's comment.
Apul sir.
Yeah.
Okay. So very nicely presented, Dr. Xavier. Just a small point. Actually, what happened, the study design in a cross-sectional study, what you showed, looked very similar to a case control study where you have a control group with no disease. So a typical cross-sectional study, to my mind, is a patient, for example, BPH. So patients with BPH who are coming to our OPD, supposing we measure the PSA, we see the prostate volume, we get a uroflowmetry, and we get the IPSS. And then we correlate IPSS with prostate volume, for example, or we correlate IPSS with PSA value, for example. So this is, to my mind, is a typical cross-sectional study. Another study, as you said, cross-sectional studies can tell you the time trend also. For example, if I see patients of hydrocele, vaginal hydrocele, a common condition in northern India. So all the patients with hydrocele, supposing I start measuring their volume, testicular volume. So what, the understanding is there's no cohort study to see whether hydrocele progresses or not, whether the size increases or not. But by doing a cross-sectional study, you are seeing patients of hydrocele at the age of 70 years, 60 years, 50 years, 20 years, 30 years. So there's a when you see a 70-year-old man and the mean testicular volume, for example, is 50 ml, but for a 30-year-old male, it is only 25 ml, then you can sort of hypothesize, or you can say that probably it's a progressive disease, because elderly men, the hydrocele volume was more as compared to younger individuals. So this sort of study designs are, good examples of cross-sectional studies.
Right, agree with you, Dr. Apul. Next time when we do a case control design, it'll be very clear as to what a case control design is. Now, just one clarification so that others don't get confused. I'm sure you know the difference. Here, what is our research question? So among middle-aged people or elderly people, okay, we are trying to look at the prevalence of, let's say, prostate cancer and the risk factors for prostate cancer. If you go to look for prevalence, you need all elderly men. Among them, some of them have prostate cancer, some of them don't have prostate cancer, right? So it is not a case control design. A case control design typically is you take a case, you collect characteristics and risk factors, and you get a matching control, right? Which we're going to do next time. Okay, so that is a subtle difference. It's a common misunderstanding among people that, and another thing that people do is they collect a group of people, let's say with prostate cancer, and then what they do is they go and find, historic control or something else, which sometimes people get a little confused. So once we do the case control design, you will be clearer about it. Now, again, if you are taking on, it all depends on a research question and what do you want to compare. So if you want to take, if your sample is everyone with bladder cancer, okay, now bladder cancer, now depending on your research question and the hypothesis that you have, what do you want to compare? What information do you want to find? You get the best information when you compare. Okay, so if people are confused, it means a good thing. That means people listened and understood a part of it, and a confused state is a good state to be in. That means thinking has been stimulated. So people who are not confused and people who don't have questions means they are blissfully ignorant. So confusion is good. I'm happy when people say they're confused. All right, good. So shall we close?
Thank
Okay,
you. Thank you
so
very much,
next
sir.
time, what I want to tell you is next time we're going to do registries and we're going to do case control designs.
Right, sir.
And we're going to have examples from the work that I have done. I've done some high quality international work in in case control designs, and I will share that with you. All right. Good night, everyone,
Right, sir.
and
Thank
see
you
you
very
next.
much.
See you
Sir.
tomorrow, not next week. See you tomorrow, right?
Tomorrow.
Tomorrow, same times.
Tomorrow.
Stay tuned. Okay. Bye. See y'all.
Thank
See
you.
y'all.
Dr. Apul, thanks very much. And
Thank you very much, sir. Apul, sir.
Thank you.
Your
Reminder-
time,
Thank you.
your
Thank
valuable
you.
time is appreciated.
Yes, thank you.